Hello, and thank you for joining us today for Preventing Prescription Drug Abuse and Doctor Shopping, Prescribing Guidelines and Intervention Skills for Nurses and Healthcare Professionals. I'm Tracy McPherson. I'm going to be your webinar moderator today. I'm a senior research scientist in the Public Health Department at NORC at the University of Chicago. I provided my email address here for you in case you have any questions about this webinar or other information or materials that you might need around screening and brief intervention. I invite you to email me, or we can set up a call. I'm really glad to help you as you're trying to implement screening and brief intervention. I'm always glad to help, so don't hesitate to contact me. And today's webinar is produced in partnership with the Brief Intervention Group, or the BIG Initiative, NORC at the University of Chicago, and the National Screening, Brief Intervention, and Referral to Treatment, or National ESPERT, ATTC, funded by SAMHSA. You can learn more about these organizations and all of the projects and the work that we're all doing around screening and brief intervention at www.esperteducation.com. Today's webinar is part of our 2016 ESPERT webinar series on special topics. As you can see, we have quite a lineup, and we still have a couple of additional webinars to go. We've done some special topics around adolescence and teen substance use. We've had special topics around gambling screening. We have one coming up on intimate partner violence. And this year we've also integrated some education around how to educate the next workforce, so how to work within nursing and social work programs and other interprofessional programs to educate students at all different levels on how to do screening and brief intervention, as well as how to use motivational interviewing strategies. So if you weren't able to join us, all of these are posted on the website, and we have on-demand recording 24/7, so I do hope that you will take advantage of that. And today's webinar is also going to be there as well, so if your colleagues were able to join you today and you think this is terrific education for them as well, you'll be able to send them to the website, and they'll be able to access the on-demand learning there. So all of the materials, including the PowerPoints, which are already posted, and any other materials or resources that may come out of today's webinar will be posted on the website. That web page is specifically dedicated to this webinar, so you'll find everything that you need to know about this webinar dedicated on that page. So any kind of materials that might come up today that we might reference will all be posted there following the webinar. You're also going to be able to find the on-demand recording posted there as well, and you'll be able to link to get your certificate of completion. So that'll be your one-stop shop for getting everything that you need to know about the materials for this webinar. We will have a question and answer session at the end of the webinar today, but I would encourage you to, as questions come to you, to go ahead and type them into the questions pane. Over typically in the upper right-hand side of your screen, you'll see a panel, and there's an area there called questions. And if you're not familiar with it, it's really easy. You can just click there, type in your question, and it will keep a running list. So if you have multiple questions, feel free to keep entering them. And we'll get to as many of them at the end of the webinar as we possibly can. And behind the scenes today is our technical facilitator, Misty Story. If you have technical questions about the GoToWebinar software or other kinds of questions, you can go ahead and put those in the questions pane as well, and she'll be answering those behind the scenes. And I'd like to welcome our two presenters today. Our first presenter is Dr. Julie Worley. And Dr. Worley has over 30 years of experience in nursing. She is an assistant professor and researcher at Rush University in their Psychiatric Nurse Practitioner Doctorate of Nursing Practice program. Her research focus is on prescription drug abuse prevention. She's a dual certified as a family and psychiatric nurse practitioner, provides primary and psychiatric care to patients, and her clinical practice at Haymarket Center, a large substance abuse treatment facility in Chicago. And our second presenter today is Dr. Niranjan Karnik, and Dr. Karnik is an associate professor in the Child and Adolescent Psychiatry section and Department of Psychiatry at Rush Medical College, and an adjunct faculty member in the Department of Community, Systems, and Mental Health Nursing at Rush College of Nursing. At Rush University, he is also medical director of the Road Home Program, Center for Veterans and Their Families, and director of the Rush University Life Course Expert Training Program. He concurrently serves as an associate faculty member of the McLean Center for Clinical Medical Ethics at the University of Chicago. His research focuses on community-based interventions for high-risk populations with psychiatric and substance use disorders. He worked at a youth homeless shelter in San Francisco and is continuing this work with homeless youth in Chicago. The major focus of his research is on using mobile health technologies to bridge the needs of vulnerable youth and enable providers to deliver services to at-risk populations. So I want to welcome both of you today. I really appreciate you joining us and sharing your expertise and your knowledge in this area. And so I'm going to turn it over to Dr. Worley to get us started.
Well, good afternoon, everybody. It's great to be here. I just wanted to give you a little background into how I became interested in this area of research. As Tracy mentioned, I have over 30 years experience in nursing, and I worked for 10 years as a registered nurse. And after becoming a family nurse practitioner, working 10 years in that field, I started noticing trends in patients coming to visit me at that time primarily for prescriptions for pain medicine under oftentimes what I found to be sort of suspicious circumstances, and noticed some patterns with that. When I went back to school for my psychiatric nurse practitioner degree, eventually I ended up having a private practice for several years, and I was practicing in a state with a quite high prescription drug abuse rate and was really being inundated with patients coming in at that point requesting prescriptions for Xanax and Adderall primarily. During that time, the prescription drug monitoring program came into existence, which we'll talk about a little bit later, and I was able to look my patients up online and see that they were not only coming to me requesting these prescriptions, but getting prescriptions from numerous other prescribers. And when I looked into the literature at that time, this was several years ago, noticed there was really a lack of research on the topic. So when I went back for my PhD, I decided to make this my area of research focus. Through the work that I've done with patients and prescribers and getting more into understanding substance use disorders, I've really had a complete change of mind about the problem and how to manage the problem. The other thing I'd like to mention before we get started is terminology. As you probably know, we've undergone some changes in how we're talking about substance use disorders over the last couple of years. We'll talk about that as well a little bit into the presentation. But I am going to be trying to avoid using the terms addiction or substance abuse, since those are sort of outdated now. But some of the slides are pre-made slides that were made a few years ago by some of the government agencies, and so you're still going to see some of that outdated terminology going forward. Okay, I'm just advancing here. So we're going to start out with a review of the neurobiology of substance use disorders. We really have scientific evidence now showing that this is a neurobiological disease rather than a choice or a decision that the patient is making. In the case that the substances actually hijack the brain, causing these changed emotions and behaviors. We do know that there is a role of environment in this, as evidenced by the fact that when many of the soldiers that were over in Vietnam had developed heroin use disorders, but when they returned, very few of them actually continued with their heroin use. And another role that environment plays is the age of onset of use. So when the younger a child is or a teenager, the younger age that they're exposed to using a substance, the higher incidence they have developing a substance use disorder, and which would be more common to happen if it's in their environment. However, it's also important to note that few people can really escape their environment, particularly those in lower socioeconomic classes. And now that we're starting to see particularly the heroin epidemic spreading out into the suburbs and rural areas, at this point, no matter where somebody lives, they're going to have access to drugs. We do know that recovery is possible, and this is always something to keep in mind so that we don't get sort of a negative outlook on this topic. It is difficult to study the actual abstinence rates and recovery rates because people that have substance use disorders sometimes are transient. So there is some conflicting evidence on the actual rates. Some studies like this one by Dennis show that you could have a pretty good recovery rate of 86% if somebody can remain abstinent or in recovery for a 3-year period, that they could have an 86% chance of being in recovery. However, the next study you'll see shows that for opioid use disorders, this study showed the abstinence rate could be as low as 30%. So we know that what happens when people use substances is that they sharply increase the levels of dopamine in the brain, but our brains want to maintain a level of homeostasis and balance. So the brain tries to clamp down on the amount of dopamine that's being absorbed. So what happens is that we'll have a downregulation of the dopamine receptors, which lead to chronically low dopamine levels and subsequent symptoms. So people that have substance use disorders who are actively using are actually walking around with very low levels of dopamine. We know that dopamine is the pleasure hormone. It's the hormone associated with happiness. So they are really not able to achieve some of these positive emotions, and this negative impact it has on their well-being is what actually drives them to continue to use. And environmental stimuli paired with the drug use elicits these conditioned response surges in dopamine that can then trigger drug craving. So you could have somebody who's been in remission a long time. They could have an environmental trigger. They could see something. They could smell something that triggers a memory about their drug use, which could cause a spike in the dopamine level, but then also a drop. And their dopamine level could end up being lower, and this is associated with relapse. So here we have a picture showing the dopamine pathway you see here in the yellow. This is the pathway of dopamine going to primarily the frontal part of the brain. It's important to know that the prefrontal cortex and the anterior cingulate gyrus are the areas where the brain is basically in a state of dysfunction for people that have substance use disorders. We know that it's not just the brain itself that controls our behavior and our emotions, but it's actually the neurotransmitters working with the brain, the physical brain. So when you have an impairment in parts of your brain, you're going to see changes, including impaired decision-making, recklessness, impulsivity, impaired cooperation, being oppositional, cognitive inflexibility, obsession, stuck on negative thoughts and behaviors. These are all the type of behaviors that we associate with people with substance use disorders. What's important is that you would have these same symptoms in somebody who had a traumatic brain injury. So if somebody's in a car accident and has a trauma to the front part of their brain, in that case it would be probably more of a permanent damage, but they will also have some of these personality changes that somebody with substance use disorders would have because of the low dopamine functioning in that part of the brain. Why this is important is because when we see someone who's had a traumatic brain injury and they have these personality changes, we are not looking at them and expecting them to change their behavior and to be more positive and to make better choices, because we can understand and accept the fact that they cannot do that because their brain isn't working correctly. But what we end up doing with people with substance use disorders who really also are in the same predicament where their brain is not working correctly and they really can't change it, is that we have these stigmatizing negative expectations of them that they should just snap out of it and do better, and that's really not possible for them. So we have to start shifting the way that we're looking at this phenomenon. Here we see PET scans. So we're able to now measure and see the levels of dopamine. On the right, you'll see in someone with substance use disorder the lower dopamine levels than the control on the left. The other important information to know is the relapse rates. You can see here, and here we have an example of some outdated terminology used here with the term drug addiction, but you'll see that the rates of relapse with substance use disorders are very similar to other chronic illnesses. So we could take an example of somebody who has diabetes who is not following their diet, they're not going to the doctor, they're eating all kinds of sugary foods and high carbohydrate foods, they are not taking their medication as prescribed, and they show up in the emergency room and their blood sugar is 600 and they're going to have to be admitted. We are not likely going to be looking at that person and rolling our eyes and thinking, oh gosh, here we go again, look at this person, they're coming in, how could they do this, this is such a shame. They're, thinking of them really as being not a nice person or some other negative feelings about them, but if we have somebody with a substance use disorder who's relapsing, who's coming in, then we do have those attitudes and feelings toward those patients. And we really shouldn't. We should really treat this just very similarly to any other chronic illness and not have any other expectations. So when we're looking at the scope of the problem of prescription drug abuse, drug overdose is the #1 cause of accidental death in the United States. It's now surpassed motor vehicle accidents. One person dies approximately every 20 minutes in this country from a drug overdose. 6.5 million Americans illicitly used prescription drugs in 2014. And the overall cost of substance use in the United States is $193 billion, $11 billion which is related to health costs. The annual cost of opioid drug disorders alone is $53 billion, and prescription drug diversion costs $72 billion. This is including law enforcement costs. And of course the impact that it has on emergency rooms with 1.4 million emergency department visits for non-medical use of pharmaceuticals, and this is 10 times greater than it was in 1995. So we're seeing huge increases in that area. Sorry, I'm having a little technical difficulty with the slides. Next, we're going to talk about benzodiazepines. We've seen another area is this with the huge increases in use. 67% increase in a tripled quantity in prescriptions for benzodiazepines. Quadrupled benzodiazepine overdose rate from 1996 to 2013. A 570% increase in the concurrent use of opioids and benzodiazepines over a 10-year period. And benzodiazepines are a contributing cause of death in an increasing number of drug-related deaths. Alcohol was involved in 27% of benzodiazepine drug abuse-related ER visits and 21% of benzodiazepine-related deaths. And about 103,000 adolescents are non-medical users of benzodiazepines. Stimulants are another class of prescription medications which are commonly misused. 67% increase in adult non-medical use of Adderall. 156% increase in emergency room visits related to non-medical use of Adderall. The rate of misuse of stimulants among college students is 17%, and 1.4 million adults use stimulants non-medically. And approximately 124,000 adolescents are non-medical users of stimulants. There's been a 39% increase in ADHD stimulant prescriptions dispensed. We're going to talk about sedative hypnotics. This is a drug class that is not always associated with prescription drug abuse, but working in the field. As Tracy mentioned, I currently have a clinical practice at Haymarket Center in Chicago, which takes up an entire city block. We have a 400-bed patient population there, including maternal child units. We have a human trafficking unit and some incarceration units. And it's not uncommon that I have patients who tell me about taking large quantities of sedative hypnotics. Ambien is the most likely drug of abuse. It induces out-of-body experiences and hallucinations. Studies have shown increased mortality and doubled MBA risk with using Ambien, not just occurring the day after taking it. Just as a sort of a side information note, something of interest, Chelsea Handler, as you probably know of her, she's a comedian, and she has a series on Netflix called Chelsea Does, and she has Chelsea Does Marriage, Chelsea Does Race, Chelsea Does Technology. She had one called Chelsea Does Drugs, and I recommend it because it's a very interesting portrayal of how people can take drugs recreationally. And in this episode, she takes several Ambien and some straight alcohol while she's being filmed, and it shows how she's interacting with a friend and playing games and doing art projects, and then the next day she is interviewed again and she has no memory of it. So it's quite an interesting documentary. So a lot of people wonder, why has there been this huge increase in prescription drug abuse? How did this happen? We know that in 1996 pain was designated as the 5th vital sign by the American Pain Society. And then in 1997, direct-to-consumer marketing by pharmaceutical companies began, which led to aggressive marketing of opioids by prescription drug companies and millions of dollars of fines paid in false advertising. And specifically the case of Purdue Pharma, which had very heavy-handed, misleading ads to consumers and prescribers downplaying the addiction potential of OxyContin, and they paid a $600 million fine for that. And in 2000, the Joint Commission stressed treating pain, and this was amended now to emphasize non-pharmacological treatment of pain, but people that have that are seeking prescription pain medicine are aware of these things. So one of the women in the study that I'll talk about that I did in a few minutes was aware of these standards, and so she would show up at the emergency room and demand pain medication. If she didn't get the pain medication, then she would file complaints. And in one case, interestingly, she was even sent a gift card and a letter of apology from the hospital administrator. And there's also been an increase in diversion of prescription drugs, and diversion includes theft, forgery, illegal sales involving a healthcare connect or somebody in the healthcare field that assists with diversion, online pharmacies, and doctor shopping. So doctor shopping, of course, has a little bit of an issue with the term, and I'm noticing that there's less and less use of the term. I'm seeing things like opioid shopping, medication shopping. The term has, though, for the last 10 years or so been used by the government, media, law enforcement, and researchers and patients. It implies all prescribers, not just doctors. That would include physicians, physician assistants, advanced practice nurses, and dentists. So the attributes of doctor shopping are that patients visit numerous prescribers, they obtain prescription drugs to be used in a way other than intended, they don't report to prescribers previously obtaining similar prescriptions, and they fill the prescriptions at more than one pharmacy. In one study of 146 million opioid prescriptions, over 500,000 associated with doctor shopping. 135,000 obtained prescriptions from 10 or more prescribers, 359,000 from 5 to 10 prescribers, and these average 32 opioid prescriptions per year. This study is a little bit outdated, but it does show the high cost of doctor shopping. In 1 year, Medicare paid $148 million for costs related to doctor shopping, and Medicaid in just 3 states paid $63 million. So what do we know about doctor shoppers? We know there's a higher prevalence of doctor shopping in the northeastern and southeastern states. They pay cash, cross state lines. The age range really varies. It's anyone from the young to the older. Higher prevalence in women in some of the studies. We think that's because they could be perceived more sympathetically by the prescribers. And in the women that do participate in doctor shopping, they have a comorbidity of a history of being abused. Other general comorbidities are mental illness, polysubstance abuse, and a history of substance abuse. There's been some studies that have been done on doctor shoppers, and one of them was the study that I did. And the themes that I found with this qualitative phenomenology studying women aged 27 to 51 are feeding the addiction, networking with addicts, playing the system, and baiting the doctors. For this study, I spent a lot of time attending Narcotics Anonymous meetings in order to gain trust of the people and their confidence, and I spent a lot of time before and after the meetings. For anyone participating in the webinar that has never attended any meeting, I strongly recommend that you do so. As you could see from the many initials after my name, I've completed several different education programs, but interestingly, I've never been required for my education to attend an NA meeting. I wasn't even aware that the general public could attend an NA meeting, that there are open meetings. And I really found that it was a very eye-opening experience to sit and listen to people, and it humanized them and put things into perspective. I was able to have a greater understanding, so I highly recommend if you ever get the opportunity to do that. As far as the themes, feeding the addiction, I underestimated as a provider that when patients were coming to see me, they were probably doing so because they had a very severe substance use disorder and would be physically sick if they didn't get the medication. I think in my mind I thought that the patients were possibly going to be using the medications recreationally. Maybe they were going to sell the medications for profit. But what I found was that almost all of the women in my study were using substances intravenously. And I couldn't tell just by looking at them that they were doing so. So I think in my mind, having as many years of experience as a nurse as I had, my picture in my mind of somebody who's using IV substances is somebody who looks very disheveled, they're underweight, they have, you know, a very haggard look to them. But what I found was these were people that were employed. Some of them, they were working as medical assistants, secretaries, hairdressers. So one sad finding in this theme of feeding the addiction was that the women reported that nobody asked them if they needed help. And so, unfortunately, I was also in the category as a provider when people were coming to me, I would just explain to them in a nice way that I didn't think the medication was good for them. It wasn't what I would recommend, that my professional judgment was that this wasn't a good medication for them, and talk to them about the reasons why. But I wasn't focusing on asking them if they needed help and keeping the door open. And so that's one way that I've changed my practice. And interestingly, when I was finishing up this study, I joined the medical staff of a new psychiatric inpatient unit, which was also a detox unit. So I had the opportunity to see patients withdrawing from opioids firsthand. Of course, I knew in my mind that yes, people get very sick when they withdraw from heroin or opioids, but I underestimated just how extreme it could be. And it is, people do detox and they have different levels of discomfort, and not everyone has as a severe reaction when they're withdrawing. But when I saw people that were, you know, laying on their bed, shaking, crying, vomiting, in severe pain, it had a huge impact on me. And I could see how if I was in their shoes, if I was somebody who was that sick, severely sick, and laying in a bed and in that much pain and suffering, that who knows if I would take a drug. How many of us could lay there and go through that? And these were people that were giving medication to help them with their withdrawal. So that had a big impact on me. Networking with addicts had to do with sharing MRIs, pills for pill counts. They would ride together. This was a very sophisticated operation. A lot of them would keep calendars of which person was working at this time because they knew which prescribers they were more likely to get the medications from. So they would work together and they would share that information about what to say, who to go to, when to go. Playing the system had to do with sometimes they would use their insurance, sometimes they would play cash, and then they would do things to falsify their urine drug screens. You can either crumble up a little piece of a pill and actually put it into the urine, or you can pull up a shot as if you were going, like heating up a pill and as if you were going to then, or a powder to inject it, and then inject a tiny bit into the urine. These are ways that they would use to fool a urine drug screen, or they could carry clean urine if they needed to show clean during a urine drug screen. And one woman described to me how she would take a pill bottle and she would put clean urine in it and she would cover it with foil and wrap it with electrical tape, and she would insert it vaginally, and then when she sat down to give the urine drug screen, she would poke the foil, she would cover it with foil, so then when she sat down, she would poke open the foil and the urine would come out. And as you can imagine, even if somebody was standing right in front of this person when they did that, it's very unlikely that they could detect that they were doing that. And there are also prosthetic penises that you can buy online that can carry urine as well. So people can be very ingenious. Baiting the doctors, this was interesting to me because they found this to be fun, thrilling, easy. It was a challenge. Some of them even talked about being addicted to the experience of doctor shopping. There were a few cases where the participants did exchange sexual favors with the prescribers or the pharmacists, but this was not as common. So the next study that I did with Dr. Karnick and another colleague of mine was a nationwide qualitative study with prescribers in psychiatry, MDs and NPs. Themes we found here were detecting red flags. This would be when the prescriber would, something would happen, they would start to sense that maybe the patient wasn't telling the truth, they would discover some other information that conflicted with the patient was saying. Then there would be negative emotional responding, both with the prescriber as well as the patient. The prescribers felt very much frustrated, disappointed. They felt like their time was being wasted. They were upset with the patient, sometimes angry with the patient. The patients themselves had negative emotional responding as well. They sometimes would have some very severe reactions. They would cry, they would become angry, throw chairs. They would rip up the money they were going to pay for the visit, and they would also make reports to the of the prescribers online for online ratings. They would give negative ratings to them, or they would report the prescribers to their supervisors. And then finally, there was some inconsistent implementing of safeguards. A few of the prescribers did check things like the PDMP and do urine drug screens, things that we'll talk about a little bit later, but overall there was inconsistently implementing of those safeguards. And some of the prescribers also did try to talk to the patients and try to help them, but most of the time what they did to address the problem would be to try to discharge the patient. They would just unceremoniously call the patients and say, you're discharged. They would try to look them up on the prescription drug monitoring program in advance of seeing them to avoid taking them as a patient, and they would basically discharge the patient. And here again this is something that I used to do when I was in my practice. I would have my nurse screen patients and ask, what medicine are you taking? And if they said they were taking Xanax, and she would say, oh no, she won't be able to see you, she doesn't prescribe that, because I was just inundated with patients and it just became overwhelming. But then the patients would still somehow get through, and I still ended up having to deal with the problem. But so these were the findings from the study with the prescribers. So what can be done about prescription drug abuse? All patients should be screened for substance use disorders. We're looking at this as more of universal precautions, universal screening. It's important to open up, engage in dialogue with patients about substance use disorders in a non-judgmental way. This is a completely new way of looking at this problem. We have to start understanding people, asking them about their experience, and trying to relate to them in a very non-judgmental way in order to help them. We want to follow evidence-based guidelines when controlled medications are prescribed, and we should identify and address prescriber collusion. It is not common, it's rare, but in the case that there might be one prescriber, say in a large practice where all the patients who are on the controlled drugs are seeing, and the prescriber is spending long periods of time in the exam room with certain patients, this is something that should be addressed. There are programs for both physicians and nurses that can help the provider, because sometimes they also have a problem, and in those cases, as long as the provider is willing to seek help, they don't necessarily lose their license. So when we're looking at who we should prescribe controlled medications to, we want to take the following precautions. We want to verify patient's identity with a photo ID and an address that matches one other form of the ID, because people do use fake IDs. Verify old records and diagnostic tests when possible. We should be on the lookout for these red flags, which most of us are very aware of being out of town, paying cash, claiming the meds were stolen or lost, asking for early refills, asking for a specific drug by name, claiming allergies or to non-controlled drugs or that they're ineffective, flattering the prescriber or eliciting guilt, sympathy, or threat, and extreme emotional responses if the requested drug is not prescribed. One thing that can be done is to put off prescribing until you have more evidence. This is particularly the case with psychiatric medications. In some cases with pain medication, if somebody has an acute trauma, you can't necessarily not prescribe them a pain medication if indicated, but for other conditions, there's usually not an urgency. In benzodiazepines, the patient should follow up with the original prescriber, or they should refer to the ER for detox because it would be unsafe to have an immediate withdrawal or stop benzodiazepines immediately due to seizures. Non-pharmacological therapy and non-opioid preferred therapy should be considered. The CDC just released a new guideline which has 12 recommendations to use when prescribing opioids for chronic pain. Chronic pain is described as pain lasting greater than 3 months or longer than what would be expected for normal tissue healing. So some of these guidelines are taken from those CDC guidelines, which can also be used for other controlled medications. Should use immediate versus long-acting preparations for opioids when possible. There's a higher overdose rate for long-acting preparations, and there's no evidence that long-acting preparations work any better than immediate acting. Prescribe the lowest dose. Should use caution if you go over 40 morphine milligram equivalents, or extreme caution over 90 morphine milligram equivalents, which you can look that up with a calculator online. Hydrocodone is milligram per milligram. So 10 milligrams, say you have a patient who's on 10 milligrams of hydrocodone 4 times a day, which to me is quite a high dose. That still does not get you to that 50 milligram morphine equivalent rate. So I've here given a couple examples of those. You want to prescribe the smallest number of controlled medications as possible. According to the CDC, that would be just 3 to 7 days. So we're starting to realize that some people can even have a procedure such as a cholecystectomy and not have to take any opioids at all. So it'd be better to err on the side of caution and just prescribe the smallest number at first, and then some patients might not even need that, but then there are some patients that might need more. You could reassess and prescribe more if needed. The reason why it's important not to just prescribe small amounts of medications is because of the resale value. A lot of times patients will take medication that they're able to get and sell it in order to, especially those with a severe substance use disorder who are injecting medications, they can inject medications that have Tylenol in them. So they would, if they get a prescription for hydrocodone, they can sell that prescription and they can buy OxyContin or Dilaudid or heroin. You can shoot up Adderall, but as you can see here, these medications have a pretty high street value. So I think some providers are apt to just say, okay, I'll give you a 1-week supply and that's it, and then they just want really to get the patient out the door because they want to avoid dealing with them, but this should really be avoided. You want to frequently reassess the need for the controlled medication at least every 3 months, and avoid prescribing benzodiazepines and opioids together. In a very large percentage of the overdose deaths in the United States, there was a benzodiazepine involved. You want to use the prescription drug monitoring program every time controlled medications are prescribed. These are statewide electronic databases started in 2013 to collect data on dispensed controlled drugs. The data is entered by the pharmacist. This is very easy to use. All states have the program except for Missouri, and each state has individual rules. In Illinois, we're able to designate a designee to check the PDMP for us. Not all states have that, so you should really check your state PDMP. Just Google your state and PDMP and you'll find the site. And it's very easy to use. You just establish a password. They do confirm your DEA license, your prescribing privileges, and then you log on, enter the patient's name and birthday, and you're able to see all the people who have prescribed the any controlled medication to the patient, as well as where it was filled. And some of the EMRs are now also integrating the PDMP right into the EMR, which is really handy. The CDC recommends checking it for opioids every prescription to every 3 months. Something I found really interesting about those CDC guidelines was that when they're talking about the PDMP, they say that the results should not be used to terminate the patient. And they say that that could actually result in patient abandonment, or that could be equal to patient abandonment if you do discharge a patient because of PDMP results. So you want to document that you check the PDMP, you will not be prescribing whatever the control drug is based on the PDMP findings if that is the case, but that you offer to help the patient, you offer to refer them for treatment, and you also discuss with the patient that you are willing for them to come back and be seen at another time if they would like to have help. There's been numerous research studies that have confirmed the effectiveness of PDMP, so you can check the PDMP Center for Excellence for numerous studies. Efforts are underway to make use of the PDMP mandatory, as well as other efforts to make special training on opioids mandatory for anyone who prescribes them in the United States. The President of the United States actually sent a letter to all governors in all states asking for them to put into law that the PDMP use would be mandatory. Other things you can do are treatment contracts, sophisticated witness urine drug screening, frequency from every time the prescription is written, or for high risk or once a year. The CDC recommends prior to starting opioid therapy, or at least annually. It's better to do the GCMS testing, which is the one you send to the lab, rather than the dipstick, because for the dipstick testing, you can't distinguish between opioids, so it's just going to show positive for opioids no matter if it's a prescribed opioid or heroin. But if you did it prior to starting therapy, at least you could rule out that the patient was actively using substances at that time. Random pill counts, validated instrument use. There's something called the addiction behavior checklist. It's a 20-item instrument that's completed by the prescriber or the nurse, which can help determine if there's any drug-seeking behavior. And while not studied, consider physical exam for needle marks. That's one thing that's very difficult to hide or to fool. So there is a lot of research out there that there definitely is stigma that exists among healthcare providers towards patients with substance use disorders. Stigma affects how healthcare providers deal with patients. Negative attitudes contribute to suboptimal healthcare. Healthcare providers lack adequate training about substance use disorders, and healthcare providers are less involved and exhibit less personal engagement with patients with substance use disorders. And this diminished empathy toward patients with substance use disorders is thought to be a major contribution to this. So it's important for us to all take a look at ourselves and ask the question if we do have some stigmatizing beliefs about substance use disorders. And some of the questions we can ask ourselves include, do you accept certain types of addiction more than others? We think about people who smoke cigarettes or people who have a problem with overeating. So we should really start to normalize these as all being equal. Do you believe some people are beyond help? Do you blame people with substance use disorders for their disease? Do you believe certain treatment approaches are better than others? Do you believe that recovery must look a certain way? And do you believe outdated theories of addiction, which are still included in a lot of our medical and nursing textbooks today, such as moral theories, conditioning theories, personality theories? So what would be the opposite of stigma? Widespread acceptance of the truth about substance use disorders, acceptance of the fact that human beings all have limitations. We want to value self-respect, self-esteem, dignity, and humanity of people with substance use disorders, have honest caring and compassion for people with substance use disorders and their families, apply a human face to substance use disorders and recovery instead of old caricatures of addiction. Recognize the courage it takes to make a transition into recovery, and have a sense of wonder at the reality of recovery in so many people's lives, and a recognition that people in recovery are normal, everyday people who live, love, work, play, pay taxes, and vote. So we want to approach patients with kindness, empathy, caring, and compassion. We want to treat people with substance use disorders the same as patients with any other chronic health disorder and not discriminate. Recognize that any behaviors of people while their disease is active is due to an impairment in brain functioning, not a reflection of them as a person or their character. This is really important because there's a huge amount of guilt and shame that people with substance use disorders have. And people can, you know, a lot of times people are using substances because they might be trying to self-medicate a mental health condition. They might have experienced some sort of trauma or they're experiencing other sort of negative emotions. You can develop a substance use disorder from medications that were prescribed. So there's a variety of reasons why people start. But what happens is that people develop this incredible amount of guilt and shame because of the things they've done while they were under the influence or while they were actively using. And they have been isolated from friends and family because they've burned a lot of bridges and a lot of people have cut them out of their life. So this guilt and shame and this isolation actually can lead people to relapse because, again, they just want to take a substance to cover up or manage their negative emotions. So in my work, when I talk to patients and I tell them, look, you couldn't have changed. When you're actively using, you cannot make a good decision. Those things that you did, that was not you doing that. That was your brain hijacked on drugs. And it really relieves a lot of their guilt, and it's good for families also to be aware of that. So again, we can't believe that people can just stop using substances. They can't do that because of this brain dysfunction as well as the severe physical withdrawal symptoms. It's really not recommended or possible for many people to actually detox themselves on their own without medical help. We want to be an advocate for patients to reduce the stigma, shame, and guilt by teaching people and their patients about this. And we need to start speaking out. I attended a conference not long ago where they had a presentation on this team steps model for working with safety in a hospital setting of teams working on safety, where they have a CUS model. And it hit me that this is something that we could do with people with substance use disorders. What CUS stands for is I'm concerned, I'm uncomfortable, and the original use was this was a safety issue, but I've adapted it to say this is a sensitivity issue. In actuality, it is a safety issue because if we are insensitive to patients with substance use disorders, they could die. They have such a high mortality rate that it really is a safety issue, because when we're insensitive, then they're not going to seek help and we're not going to be able to help them or intervene. We want to avoid the words like addict and abuse. Those were removed from the DSM-5 because they're hard to define and have negative connotation. It's really a challenge to change the way that we talk about these things, but when we hear someone say so-and-so is an addict, it's good to speak up and say, you know what, we're not really using that term anymore because it just sort of makes people have bad feelings about people that use substances, and we're using the term substance use disorder. I've had to do that with some of my colleagues. We don't want to define people by their disorder. We don't want to say someone's a heroin addict or a drug addict or an alcoholic. We want to say they have a heroin use disorder or people with alcohol use disorders. We want to avoid sensationalizing terminology like someone suffers from something or someone's afflicted with something. We want to keep things a little bit more neutral. We don't want to make generalizations about people with substance use disorders. There's no such thing as an addictive personality that all people with substance use disorders have. There's a wide variety among people with substance use disorders. So how do we assess people with substance use disorders? We can use SBIRT, which is Screening, Brief Intervention, and Referral to Treatment. This is an evidence-based method. It's reimbursed by Medicare. There are ICD codes for this. It can be conducted by office staff and nurses and done in a very short time frame, just 5 to 10 minutes. It involves pre-screen questions, which would include do you drink alcohol, and if so, how much, or do you use illicit drugs or medications non-medically? And then you follow that up with a validated instrument such as the alcohol use disorder identification test or the drug abuse screening test. This is then followed with brief intervention using motivational interviewing and then a referral as indicated. There's many online sources for SBIRT training and videos, and I highly recommend, if you don't already have this type of a program in your workplace, that you recommend it. But assessing people with substance use disorders can be done through a conversation. You just sit down with the patient and ask them questions about their substance use. And the best way to talk to people that we have is motivational interviewing, which is an evidence-based method to address any behaviors that need to be changed for the good of the person. This could include medication non-adherence. It could include self-injury. It can include people's eating patterns. But it's also very good for use with substance use disorders. It's based on the premise that you generally care about the patient and their well-being. Based on autonomy, not authority, it's a non-judgmental interviewing process used to help people explore and resolve indecisiveness about making changes in their lives. It builds on the relationship and rapport between the patient and the healthcare professional, helps patients through their own self-reflection become more aware of their need to change. Patients do more talking than the healthcare professional. So this is the opposite of sitting down with a patient and sort of lecturing them and with this laundry list of all the reasons why they should stop drinking or why they should stop using substances. I think we've had plenty of time to realize that that simply does not work. It's based on collaboration, not confrontation. Some of the key strategies: you want to approach patients in a friendly, genuine way. Patients can tell if you care about them. If you really have some very strong negative feelings about the patient, you should probably not engage them in motivational interviewing. Maybe you can find somebody else who can do it. I also like to think about patients as, that's somebody's daughter, that's somebody's son, that's somebody's brother or sister, and try to think about all the good qualities you can about the person to develop some empathy. Ask permission to talk to the patient about their substance use. If they say no, you can try to say it will only take 5 to 10 minutes. Ask if you can discuss it later. And if they still say no, you can leave them with some information. Acknowledge their substance use and ask them to tell you about it. What is their day like, or what is their experience with using substances? So we can't really develop a relationship with someone if we don't know anything about them, if we don't understand them. So we should be willing to sit down and ask them to tell you about their experience. And people with a heroin use disorder are probably going to say, well, I get up in the morning and I'm terribly sick, and then I have to go out and I have to try to find some drugs. And so you can empathize with them and say, wow, that sounds really difficult and that sounds scary, because it is a very traumatizing life that people have to lead. Ask what they like about their use, what's good about it. A lot of people will tell you that the reason they do it is because they're trying to numb some of their bad psychological symptoms. They might say, well, I've had my kids taken away, my sister was killed, I'm homeless, and so they just want to take the drug or the alcohol just to numb themselves. And so you can empathize with that. I can see how that would help you, to help you cope with that. Then you ask what they don't like about it and why. This is important because you're wanting the patient to come up with the reasons of the negative impact that it has on them. And then you can ask if they have any motivation to change their substance use or reduce it. The readiness to change ruler is a great technique. You're going to ask the patient on a scale of 1 to 10, how ready are you to change or cut back on your substance use? It's nice if you have an example. You can get little cards that you could carry around in your pocket. Whatever number they choose, ask why they didn't choose a lower number. This can be somewhat confusing and hard to kind of grasp the concept of this. But what this does is prompt the patient to come up with their own reasons why they should change. You want to keep encouraging them to talk about this and keep asking what are more reasons. For example, if you say to a patient, how motivated are you to cut back on your drinking? And they say, well, I don't know, not really too much, maybe a 5, maybe a 5. And so then what you would say is, why not lower, why not a 2? So then the patient might say something like, well, it does cost me a lot of money, and my wife really hates it when I drink, and I do feel really bad in the mornings after I drink. And so this is the patient coming up with those reasons instead of you. So then you can say, is there anything else, or tell me more about that. They say 0. Occasionally it happens, very rarely, but I have had it happen to me a few times where the patient says they're not ready to change at all. And if that happens, then you can ask what things would happen or be present for them to want to change, or what would signify a problem to them. Again, getting them to come up with those reasons, not you. So then you can set some goals with the patient. Ask what they could do to meet those goals of changing or cutting back. Some of those things patients sometimes say: finding new friends, stop hanging around with certain people, not going out as much, trying to get help. If you can, put it into writing. Say, oh, this is great. You know, you've really come up with some great goals. Let's put this in writing. You want to give referrals when indicated. If treatment is indicated, it's best to make an appointment right on the spot if you can. You want to close with encouraging positive statements. Thank you for being willing. You've come up with some great goals and strategies. Let me know if you have any further questions. Here's some websites on expert in motivational interviewing. So what can be done when prescription drug abuse, what can we do about prescription drug abuse? We want to remain non-judgmental and supportive, offer alternative treatment, offer help and referral to treatment, keep the door open, and treat the drug use disorder when appropriate. We want to, when doctor shopping or prescription substance use is identified, and we want to report it to authorities when applicable, because there are some Medicare and Medicaid fraud laws in some states, and even some doctor shopping laws. Now I'm going to turn it over to Dr. Karnick, who's going to discuss with you some treatment modalities for prescription drug use disorders.
Hi, good afternoon, everyone. Thanks for joining us. I just want to note, Dr. Worley, who's done the presentation to this point, really has emerged as a national leader in this area, and it's really been a privilege for me to be able to collaborate with her on this work. So among the treatment modalities for prescription drug abuse, there are a number of choices. There are medication treatment options. So, many people in the audience are probably aware of opioid replacement therapies using methadone or Suboxone. Methadone is, of course, a closed system by federal law and has to be administered on site. Suboxone certainly is an office-based modality. We are seeing increasing demand for Suboxone treatment. Providers who have not, undergone the training certainly can do so. The Society for Addiction Medicine has a free online training course that people can do that they can do the required 8 hours that the FDA requires in order to get your special buprenorphine license, a DEA-X license. So those, I would encourage folks to explore those options. In addition, there are opioid antagonist treatments like naltrexone. The oral version of this has been underutilized, and there are IM preparations which I think are a little bit more popular right now, like Vivitrol. That is soon, or I think has recently been released as an implant version. These products need to have some type of bracelet or identification on the patient that they are on this medication. If there is some acute injury, if there is a need, for the person to take medications, in the right setting, this can be overridden in an inpatient unit. Providers should be aware. I think patients sometimes think that these medications protect them in some ways from overdose. This is not really the case. These medications can be overcome. What we often see are individuals who are trying to take aggressive amounts then of opiate to overcome some of the effect of this medication, and can, the pharmacokinetics of some of these of naltrexone is such that if they surpass a certain point, they might sort of go off the cliff very quickly in terms of the toxic effects of the drugs. So it's important to have that discussion with patients when you're putting them on naltrexone, or if they're taking naltrexone-like products, because this is a significant risk, and it doesn't ensure 100% protection against opiates. In addition, there are many non-pharmacological treatment options, and clearly I think medications should be used in combination with non-pharmacological options. Using them in isolation rarely leads to recovery, but you really do need to tailor these treatment options to the individual patient. So therapy, various different types of psychotherapy, can have effect. Certainly thinking about, I tend to phrase it as sociotherapy as well. So you want to think about the social context in which drug use is happening. It's a powerful motivator, and to the extent that we can work with patients to improve their social context and to change the social factors that might be promoting drug use, they're likely to have more success. Support groups are definitely an important option. Narcotics Anonymous, Smart Recovery, there are many different types of support groups. I think in my experience it is really about finding the right fit for patients with particular support groups, both culturally and morally and philosophically. I think patients need to feel like they are with people that they can empathize with, that can understand their experience. And then there are, layers of intensive treatment. So certainly inpatient detox, the classic 28-day rehabilitation program, intensive outpatient programs are certainly an option, and transitional living. My experience is that the quality of these programs varies dramatically. So I would encourage providers to really, look into the local resources, try to find out, talk to people so that you can identify what are the quality resources in your area. And I tend to refer, folks to a rather small number of programs that I have faith in when I do make these types of referrals. And let's see here. So, sorry. Overdose prevention is a major priority right now for all of us. This is on the top of the U.S. government's list in terms of trying to increase safe prescribing, increase treatment. SAMHSA is rolling out a variety of initiatives in this area. Naltrexone is being used widely to try and prevent overdose deaths. Naloxone is an opioid antagonist that rapidly knocks the opiates off the opioid receptor. And this has been used to rescue individuals in overdose situations. There is increased risk of overdose for certain populations, including individuals who are older age, those who are mixing substances, so substances that have like effects or that are overlapping in their pharmacokinetics can increase the likelihood. But also there can be opposite effects where one substance increases the blood level of another, and those types of situations. And some of the drug users that I've come across, they're trying to cocktail their mixes in some ways, if you will, and that can be a very risky endeavor from my perspective. Often individuals starting back who go back and relapse into using drugs after a period of abstinence may over-anticipate what they need. So as we know, tolerance develops over time, and if they have gotten a degree of abstinence for a certain period, their tolerance might have dropped, but consumers, individuals who use drugs may not be aware of that. And so if they return to their previous dose, they would be at higher risk of overdose. And finally, taking high doses of substances, of course. There is no quality control for illicit substances, and there are widely distributed reports of cutting of different drugs with other drugs. For example, locally in Chicago, we've had a number of deaths due to heroin that was mixed with fentanyl. And so these types of mixtures, put drug users at extreme risk. And one of the things that I have pointed out repeatedly to some of the individuals that I treat, but also with fellow providers, is that across the board we have seen an increasing sophistication on the part of individuals who make these illicit drugs, and this is even true to some extent for cannabis, which is grown. And what we see is these individuals who are providing these substances are able to understand the pharmacokinetics much more deeply and are creating higher potency substances. And I think that this is almost across the board, increasing risk in various ways. So as I often tell individuals in my practice, these are not the substances, even though they may be termed by the same names. Functionally, these are not the same substances that existed 10, 20, 30 years ago in some cases. Some substances are, to prevent overdose, some of the treatments are available both in an injectable form and a nasal spray. way, and that allows easier administration in emergency situations. Some states have policies or laws that allow anyone to administer these medications. Others may require training. And often these overdose prevention or overdose treatment medications can be dispensed by pharmacists, and in some localities they can be obtained over the counter. So now we're going to move on to a couple case studies, and just to highlight some of the principles here, and we hope that this will then lead into a productive discussion and question and answer period. So let's start with the hypothetical case of Martin, a 32-year-old new patient who presents with tooth pain lasting several weeks and is requesting pain medication from you. On physical examination, you find no abnormal findings. Martin rates the pain at 8 or 9. It interferes with his life. You check the prescription drug monitoring program database and find that he's had 4 prescribers in the last 6 months for controlled medications, including opioids and benzodiazepines. Martin refuses a urine drug screen. You discuss with the patient and engage in some degree of motivational interviewing and try to ascertain what's going on. And you offer referral to treatment. In this case, it's pretty clear, the 4 prescribers in 6 months, the multiple use of opioids and benzodiazepines, is a big red flag in some ways. And what you want to do is engage Martin in treatment and not just write the controlled medication prescription. In contrast, Lori is a 54-year-old new patient who's come to the area and presents with rheumatoid arthritis. She takes hydrocodone, as needed for severe pain flares, usually about 10 times a month. The last one was taken about a week ago. Her last prescription was about 90 days ago. On physical assessment, you confirm her diagnosis and you ascertain that the symptoms are concordant with rheumatoid arthritis. She likewise rates her pain at 8 or 9 when the flares occur, and at those times it does interfere with her life. You obtain consent from her, and the diagnosis and treatment are confirmed by a prior provider who will send medical records. You check the prescription drug monitoring program database, and you find 1 prescriber for the past year. Prescription of 30 tablets and used over 90 days was filled about 90 days ago, and her urine drug screen is negative. So in this case, you establish a treatment contract that includes some random pill counts and urine drug tests. You implement the use of addiction behavior checklist starting with the next visit. This is an opportunity to monitor and make sure she doesn't develop a significant degree of a use disorder with this medication. And in this case, you would feel, I think, much more comfortable prescribing the hydrocodone as she has been taking. She appears to be using it quite appropriately for her rheumatoid arthritis. And, I would also, venture to guess that we probably, in a general practice setting, want to refer Lori to a specialist to see if we couldn't get her flares under better control, which overall might reduce her exposure to opiates over time. So these are 2 kind of, just example cases, to think about in terms of, how these situations might emerge in practice settings. So we end with, don't give up on these patients. Don't give up on this area of work. We all have patients who come into our practices like this, and I think, it can get disconcerting at times and disheartening when we see these situations emerge. But certainly, I think engagement with these patients can be a very productive relationship, and providers can do a great deal of good. Tracy, I think we're going to turn it back to you to moderate our questions.
Yes, thank you, Dr. Karnick, and thank you, Dr. Worley. What an excellent presentation. I've learned so much already, and I'm looking forward to going back and listening to it again. I think this is a lot of new information for many people as we, in an interprofessional environment, we are learning different roles. When we're not a nurse, we're a psychologist, we're a social worker, we come from various places, and learning what our roles are in addressing prescription drug use. And so I think this has been extremely valuable to the the attendees today coming, as I can see from the attendance list, from all sorts of backgrounds, so thank you. I want to remind folks for where you can submit your questions. There's a questions pane typically in your upper right-hand corner. You can just simply type in your question. We have a couple of questions that have come in already. And let me pull these up. So one question, and I get this question myself, so this question is for Dr. Worley, and you were talking about some of the screening tools, including the DAST, and in this person's experience, they found that the DAST is problematic in its use because for a couple of reasons. One is that some of the questions, you were talking about stigmatizing language and new language that we're using now, and some of these tools were developed many years ago. So there's a particular question, do you abuse more than one drug at a time? And so patients are often put off by this question. Would you suggest a newer tool or less stigmatized tool, yet it's still valid? What are your thoughts on that?
That's a great question. I think it takes years to develop an instrument, so we are using instruments that have been around for a long time. The language has really only changed within the last 2 years. So it's going to take some time, and I'm hoping that some of the instruments that we have will be changed, but then they're probably going to have to be validated again. I think one way to handle that, because I'm not aware of any instruments out there that don't have any stigmatizing language, just the name of the instrument, drug abuse, is a term we're trying to avoid. I think the way that I handle that is to just say, explain to the patient that that terminology is in there, but we would like them to just talk about their use, and we can talk about the terminology. I think that most of the patients they tend to use a lot of that stigmatizing language against themselves, to be honest. They describe themselves as addicts. They talk about being drug abusers. So it might not be as sensitive of an issue as we think it might be. I think at this point, until we have better, more updated instruments that don't use some of these stigmatizing terminologies, is to just let the patient know up front, look, this term it does appear on this instrument, but please don't let it offend you. We're just really wanting to learn because we care about you, we're interested in your safety, and just give an explanation.
Yeah,
and Julie, can I add something to that?
Yes, please.
I would suggest also that some of the instruments that we use are actually can be used both in a written form, but also given by the provider verbally. And when you do it verbally, it gives you the opportunity to kind of soften that language a little bit, or add a little caveat to it. I mean, we want to retain the language of the instrument as closely as we can in order to retain the validity, but sometimes when we do use it in spoken language, we can moderate that a little bit more easily.
Yes, thank you very much for your comments on that. One of the things I would mention, and this has come up recently in talking to some representatives from the Clinical Trial Network at NIDA, they were mentioning that some of the studies coming out on some of the newer tools that are, the psychometric studies are being done, and they're in the midst of looking at results and trying to get these published. But they've posted on the NIDA website, in collaboration with the American Psychiatric Association, and these are not necessarily easy to find if you didn't know to Google them this way, but if you type in APA emerging measures, you will see they've already posted some of the tools that are being studied that we will see psychometric studies being published. So I don't know if people are using them routinely at this point, but the conversation I had with those representatives was that people should feel comfortable, they should begin to use them now, and they feel very comfortable recommending them. And they actually list specific substances, which is the part B of this person's question is that some of these tools ask about general use, not specific substance use, and so I'm offering that because these sets of emerging measures are by substance, but they're very brief. So I throw that out there as another thought. Okay, let's see, we have a few more questions. And this is more of a medical question. So, and it's not directed at either person specifically, so I'll just throw it out there. Can dopamine levels go back to normal or levels prior to substance use after a certain number of years abstinence?
Yes, they do, and we don't. It's very difficult to, measure this and study the brain. But anecdotally, and I think what is considered to be the standard response when we talk about that is about 3 to 6 months. So it does take some time for the brain to adapt and get that balance and homeostasis back. One thing that can be done is exercise. Exercise can increase dopamine levels, so I do highly encourage that in the patients, and just to offer them the reassurance that while we don't know exactly when, because everybody's different, we know that people have differing levels of neurotransmitters, even genetically, and which is why some people develop mental health disorders. So we can't really predict exactly when, but I think it's pretty safe to say that it will take about 3 to 6 months, and that then people will start having some of those normal experiences of feelings of being happy and enjoying life. Because a lot of times my patients will ask me, when am I going to have fun again? When am I going to enjoy life? And I just encourage them to wait it out, do the best they can, hang in there, because if they go back to using, then it's going to just erase the whole process of healing in the brain. I don't know, Niranjan, do you have any other thoughts about that?
No, I would just say that I think that there's a lot of variability around this too. I think you're spot on, and I think one of the things I think people should be aware of is that there hasn't been a lot of really good longitudinal research in this area, of following people out. Especially from the point of recovery and trying to track these type of biological effects.
Great. Well, thank you for. I think that's very, very helpful. So let's look at the next question here. What information can be provided to employers to educate them on substance use disorder? To educate them on substance use disorders as an illness and not as a modal dilemma for employees suspected of substance use. So I think the question is, what information can be provided to employers to really educate them on substance use? And you've been talking about it as a medical condition, a medical disease or illness. And do you have any thoughts around good materials that could be provided to employers?
I think NIDA probably has some of the best information that I've seen out there. There's a lot out there, but I would strongly suggest that website and that agency for one, and SAMHSA as well. But I think if you just Google it, you're going to come up with many, many sources, and it just is a matter of just getting the education out there, finding someone maybe to come into your workplace to do a short in-service, for example, giving people articles, sharing websites. As healthcare professionals, we can be ambassadors for this, getting the word out about substance use disorders, about using naloxone, getting naloxone in the hands of patients and their families if people have substance use disorders, or just sharing that information because the person you're talking to will know someone who might need it. So getting the information out there, there's lots of online PowerPoint presentations, lots of TED Talks, YouTube videos. There's really a plethora of information out there, but I particularly like NIDA. Dr. Karnik, what do you think?
Yeah, I think both NIDA and SAMHSA have really good websites. I think the other thing that is encouraging in that question, I think, is that one of the things I think we're starting to try and move to is less of a focus of, looking at the significantly impaired population, which we all know needs treatment. The substance using population is quite large and also heterogeneous, and we're trying to move more towards a prevention model. And I think this is where employers can play a really key role, because one of the things that we want to do is have robust employee assistance programs, EAPs. We want to have employers be able to recognize that taking a prevention approach actually saves them money. I mean, the economics of this are clearly on the side of early intervention and early treatment. Employees who get exposed to some of these models and some of the treatments and prevention strategies early on, like ESPER, are much less likely to miss days due to illness. They're much less likely to develop other expensive medical conditions that affect the employer's health plans. So I think that needs to be part of the education too, in addition to just raising awareness of this, that the economics of this are all on the side of us doing more of this up front, and for employers to have relatively, if you will, liberal policies about enabling employees to get care and get connected early on, because the outcomes are just going to be so much better for them as a company.
Well, thank you. I certainly appreciate that comment very much, as someone who's dedicated more than 15 years of their work to workplace substance use and mental health, and working with employee assistance programs and various health plans. And I can see today we have a number of different companies that I've worked with and I haven't, who are very much in the workplace space. In fact, I see some folks in EAP and managed behavioral health care, and so I'm sure they appreciate that as well. And we are seeing more and more everyday questions coming in from workplaces and their health plans saying, well, what can we learn from the medical community? What can we do in this space to help beyond that prevention, early intervention side? And the research is out. We don't know. We haven't studied whether doing screening and brief intervention and EAPs for prescription drug use, we don't know whether it's effective, but we're starting to see a lot more interest in the potential of asking these questions early, which tends to be done in the medical side, more in the behavioral side. So I appreciate the question and the response. We have a couple more questions that have come in. What are new modalities for cannabis addiction withdrawal? I think it's for treating. What are new treatment modalities for cannabis addiction withdrawal?
Well, there are no, sorry.
Go ahead, Julie. Go ahead, Julie. Yeah.
There are no FDA-approved medications for that. It is one of the top reasons for treatment. However, I think people just automatically assume one of the top reasons for admission to treatment is opioids, but actually there are more admissions for marijuana. But we do know that the marijuana of today is a lot stronger than the marijuana of many years ago, where there was 10 milligrams of THC per a dose of marijuana, which now it's 50 to all the way up to 300 milligrams. So we're starting to see, there's different strains. They're genetically modifying it. There's a strain that's more of a sedating strain, and there's a strain that's has more of a hallucinogenic effect. So really, if somebody is in treatment, you're going to use a lot of the, therapeutic interventions, cognitive behavioral support. As far as medications, you're probably not going to be using medications, though. Dr. Karnick, do you have anything to add?
No, I think that that's true, and I think that there's a number of people who are investigating in this area. We definitely see sort of a post-withdrawal, like anhedonia. People really have a hard time motivating. They have a hard time concentrating sometimes, and this is especially true for folks who are long-term users of cannabis, tend to kind of have this this state that can be sometimes hard to break out of. And I think that there are emerging research groups that are sort of starting to work on this. I think the sort of legalization movement around the country has really prompted this in some ways, and so the federal government, NIH, are investing resources in this area to examine these questions.
Right, and so some of those symptoms are probably due to, again, the lower dopamine levels that are resulting from, the chronic use of a substance that's raising the dopamine level, which marijuana does, as well as alcohol or any sort of drug. And that's why you'll see with the opioid replacement therapy, the medication-assisted treatment, you're actually giving somebody a low dose of an opioid like Suboxone or buprenorphine or methadone because they basically can't function with their dopamine levels are so low that they're just really not able to function, and then in addition it's just giving a little bit of a boost so they don't have the withdrawal symptoms. So, as far as neurotransmitter-wise, looking at medications, it's possible even a medication like naltrexone could be helpful for people with marijuana use disorders, and so there's all kinds of ongoing studies in that area, but nothing's FDA approved yet.
Thank you. Thank you. All right, let's see, we have a little bit more time. Let me identify a few more questions for you. Do you anticipate the remaining U.S. states implementing doctor shopping laws, and do you think this will be a slow process?
Well, it's controversial about the doctor shopping laws because the doctor shopping laws mean that you have to report somebody to law enforcement. The goal of all of the measures really should not be punitive. The goal of doing urine drug screens or looking people up should really be for safety and to help the patient. So it's somewhat controversial. A lot of times there's a mental health exclusion. I was actually practicing in a state where they did have a doctor shopping law where it was a reportable offense. However, they had a mental health exclusion, meaning that if you were working in the mental health field, you had the option to not report. But it becomes a slippery slope when you start wanting to criminalize substance use. We've seen that with pregnant women. I think the focus should really be on providing help for the patient, identifying the problem, preventing the problem through safe prescribing to begin with, but then also really trying to help the patient. So it's controversial about whether this is something that should become a law where people are automatically being reported to the police because these are people that often have co-occurring mental health problems, experienced a lot of trauma, and so then we're just sort of putting people in jails and prisons with mental health problems, and they're not really getting help there. And so I don't think that we're going to see those laws expanded because you're really seeing a big change in the idea of approaching this as a medical problem and not as a criminal problem. President Obama has actually been pardoning a lot of people who had a lot of drug offenses, and we're trying to not just keep throwing people in jail about this, but we're actually trying to help them and improve their quality of life. So I see the trend moving away from criminalizing it.
Okay, thank you. Thank you. Well, we're getting towards the close of our session today. There are a couple of other questions about resources and information about screening and brief intervention and referral to treatment, or we fondly call SBIRT, and motivational interviewing. And there are several questions about the use of SBIRT motivational interviewing around prescription drug use in different types of populations, including obstetric patients and other patients. So what I wanted to just let folks know who may not be aware is that if you go to our website, the sbirteducation.com, it was shown at the beginning on an earlier slide, there are resources that cover screening, brief intervention, referral to treatment, motivational interviewing. We have them, we're redesigning the website to even pull out for specific types of patient-client population so that you can click very quickly over to content. You may see articles, there are on-demand learnings, there's education like what you have heard today about specific populations. So all of this is made available to you for free and on demand. So I would highly encourage you to go and take advantage of those resources. The development of all of this has been supported through the National Expert ATTC and SAMHSA, and so it's all available to you. So I want to just close by saying thank you so much to Dr. Worley and Dr. Karnick for your excellent presentation and discussion today. And I wanted to remind everyone, if you go to the website, the URL is listed on your screen. This page is where you'll find the PowerPoints. You'll be able to access your request for a certificate of completion and your request for the 1.5 CE credits made available today through NADAC. The on-demand recording will be there. If there are any other resources we think would be useful that are related to this, we'll put those up there. And also you'll find a link to the evaluation survey. So for those of you who are live today, you already see over in your question and answer chat pane area, you'll see a link to the very brief evaluation. It's really important, and we would really appreciate you taking about 30 seconds to complete that evaluation. It really supports the work that we do, and it really is one of the ways by which we are evaluated is by your evaluation. So it's really critical that you complete that. And I wanted to let you know if that you want to watch this again on demand, or you want to give this to the information to a colleague to watch on demand, we would appreciate that once you go through the on-demand session, that you'd return to the web page and complete the on-demand evaluation survey following your completion. And you will also receive a follow-up email that will have additional information about the links of where to access it and all the things I just talked about. So that will be summarized. But we would greatly appreciate taking a few minutes to do that. And last but not least, I just want to close by saying that please join us in June for our webinar on intimate partner violence. And I think we're going to have a couple more coming as well, and so keep an eye out for that schedule. We're going to be adding some coming soon. And last but not least, I want to say thank you to all of you who've actually taken time out of your schedule to join us today for this and all the webinars in our series. If you would like more information about expert implementation, evaluation, and training, you're looking for some telephonic technical assistance or email, you're welcome to email me. I'm welcome to have a conversation with you on the phone, and anything we can do to help facilitate some of the challenges or find resources that you need. So thank you everyone for attending. Thank you again, Dr. Worley and Dr. Karnick, for this excellent presentation. And thank you to the National Expert ATTC and all of the partners in making this education possible. I hope everyone has a great day, and thank you for joining us.